Good morning, all. Respected seniors and my dear friends. After that excellent brainstorming session on LDL cholesterol by Jabir sir, I'm not sure how many of us are really inspired to listen to a session on hypertriglyceridemia. So over the next 7 minutes or so, we'll be looking at hypertriglyceridemia updates. The domain of atherogenic dyslipidemia has always been heavily in favor of LDL cholesterol. However, as Jabi sir had mentioned in his talk, the real menace is ApoB containing lipoproteins less than 70 nanometer in diameter. And when we look at ApoB containing lipoproteins less than 70 nanometers, it is obvious that VLDL is a major player, and it is a triglyceride containing lipoprotein. Plasma triglyceride concentration reflects the concentration of circulating ApoB containing triglyceride-rich lipoprotein remnants. And it has been shown that lowering triglycerides with fibrates reduces the risk of cardiovascular events by the same amount as LDL cholesterol lowering therapies when measured per unit change of non-HDL cholesterol. In atherosclerotic cardiovascular disease management, at present, triglyceride has been relegated the status of a risk-enhancing factor, which aids in decision on statins in primary prevention patients at borderline or intermediate risk. Now, the pathophysiologic profile of hypertriglyceridemia is beyond atherosclerosis. It involves acute pancreatitis as well as non-alcoholic fatty liver disease. Now, when we encounter a patient with hypertriglyceridemia in our general practice, what we need to remember is that it is not a single entity. Most often, it is secondary to a systemic problem or medications, or it could be due to genetic problems. One of the rarer but the most severe form of hypertriglyceridemia is familial chylomicronemia syndrome, which is Fredrickson type 1 hyperlipoproteinemia. It's a monogenic disorder with markedly reduced LPL activity with triglycerides in the range of more than 1,000 and very resistant to treatment. However, it is rare. Now, in our common practice, most often the young adults presenting with persistent hypertriglyceridemia more than 500 usually belong to this category of multifactorial chylomicronemia syndrome. This is a polygenic form of hypertriglyceridemia with minor defects in multiple genes, but complicated by one or more conditions that aggravate hypertriglyceridemia. And the secondary factors include diabetes, alcohol excess, obesity, hypothyroidism, and medications, thiazide diuretics, non-selective beta blockers, to name a few. Now, treatment of hypertriglyceridemia, the step one is obviously addressing the inciting factors. Address and identify the secondary causes. The secondary causes for hypertriglyceridemia, like control of diabetes, hypothyroidism, abstinence from alcohol, and a replacement of implicated medications. Step two, lifestyle modification. Interventions like weight loss have been shown to reduce triglycerides by up to 70%, and physical activity reduction by up to 30%. Lifestyle modification also includes dietary management, which is not just reduction of fat intake. It is also about reduction of carbohydrates and replacing with high fiber diet. Now, triglyceride levels are inversely associated with carbohydrate intake. As we know, excessive dietary fat leads to excessive chylomicrons, whereas excessive simple carbohydrates lead to excessive VLDL production by the liver. And studies have shown that higher fat, lower carbohydrate diets are associated with greater reduction in triglycerides as compared to lower fat, higher carbohydrate diets. Now, in FCS, familial chylomicronemia syndrome, it is a problem with LPL gene. So there is excess chylomicrons. So naturally, the focus has to be on dietary fat. But in the more common MFCS syndromes, since there is excess VLDL as well, studies have shown that a low carbohydrate diet without reduction of fat has been as good as a low fat diet. Now, we can see the triglycerides more than 10,000. If you look here, added sugars have to be eliminated. But still, a fat of 10 to 15% is allowed. Now, step 3 of treatment consists of drugs. We have a whole gambit of drugs like statins, fibrates, omega-3 fatty acids, nicotinic acid, saroglitazar. But the principles of pharmacotherapy, a non-statin pharmacotherapy is generally not indicated in mild to moderate hypertriglyceridemia, which is triglyceride levels less than 500. However, when triglyceride levels are more than 500, fibrate therapy is indicated to reduce the risk of pancreatitis. Despite 4 to 12 weeks of lifestyle intervention, statin therapy, and treatment of secondary causes, if fasting triglycerides remain to be more than 150, it is persistent hypertriglyceridemia. Time to consider non-statin therapies, but still dependent on ASCVD risk factors and diabetes. However, as we can see here, the primary interest is always on intensification of statin therapy. And icosapent-ethyl, which has been shown to have a beneficial effect on ASCVD, has been recommended with a class 2A recommendation by ESC. The key point is that no fibrates yet. However, when it comes to severe hypertriglyceridemia, in addition to intensification of statin therapy, low-fat diet, fibrates, and omega-3 fatty acids. In severe, very severe hypertriglyceridemia, more than 1,000 milligrams per deciliter, we have to resort to very low fat diet, like 10 to 15% of calories, restriction or elimination of added sugars, strict glycemic control with insulin plus drugs, and the final go-to method may be a plasmapheresis to bail a patient out of the risk of pancreatitis. Future, gene replacement therapy has been tried. Tipavuvac is tried in patients with familial hypercholesterolemia type 1, quite expensive. Now the interest is on targeting LPL regulators. ApoC3 inhibition by an ASO antisense oligonucleotide, volanesorsen, has been shown to be effective. This has been approved in European Union, awaiting FDA approval yet. The latest focus is on LDL triglycerides, which has been shown to be a harbinger of systemic inflammation, and elevated triglycerides were found to be associated with an increased risk of ASCVD in meta-analysis. Take-home messages: ApoB containing triglyceride-rich lipoprotein remnants are atherogenic and are reflected by plasma triglyceride levels. Plasma triglyceride levels are inversely associated with dietary carbohydrate intake, and statins remain to be the initial drugs of choice for the management of hypertriglyceridemia less than 500. Thank you.
Excellent talk, Amel. I think there are two key points from your talk. One is the mild to moderate hypertriglyceridemia, less than 500. Everybody starts fibric acid derivative, and so many companies are coming out with statin fibrate combination. I think it's a dangerous combination and we should avoid. So that should be a message. So there is no indication for treatment for triglyceride elevation below 500. Unless in extreme cases. I mean, no, the American guidelines say no fibrate. So I think you can leave alone, even if the triglyceride is 400 or 300. Secondly, the fat. Immediately, most of the consult physicians recommend fat restriction in mild hypertriglyceridemia. That is the opposite effect. You pointed out rightly. So there is no need to restrict fat if the triglyceride is less than 500. If it is more than 500, it is chylomicron. And there you have to restrict your fat. And thirdly, good diabetic control. I think you have pointed out that. Good diabetic control. That brings down the triglyceride. Thank you.